Hi, this is Dr. Doerr for Functional Soft Tissue, and right now we're doing our second video of the month for lateral epicondylopathy, which is going to be our FAKTR treatment for lateral epicondylopathy. Now, because this is an epicondylopathy, and just like we talked about in that first video, remember if you treated this a couple of times and it's really not showing any progress, you really got to make sure that you look at the wrist, the shoulder as your starting points before you start analyzing the rest of the kinetic chain. Frequently we can have shoulder or wrist injuries that are actually provoking the lateral epicondylopathy, and this is more of a symptom, not the problem. However, for the purpose of this video, we're again going to just do a FAKTR treatment associated with the lateral epicondylopathy. As we talk about all the time in FAKTR, when we have tendinopathies, knowing that they respond so well to eccentric loading, much like in the video that we showed with Achilles tendinopathy, we're going to do an eccentric load with our lateral epicondylopathy. So what we're going to do with our patient is we're going to have them start into that concentrically loaded position. We're going to have them do what's called a Tyler twist. So we're going to bring them into that concentrically loaded position. We're going to twist our flex bar and have that slowly load down into an eccentrically loaded position. So we'll have our patient hold there. First we'll take out our FAKTR emollient. And today we're using one of our FAKTR instruments for treatment. So let's have our patient load up that tendon. We're going to go into a concentric position. Go ahead and twist that flex bar. Now he's going to hold that up straight and slowly let his elbow come across while we work on the tendon. Now I'll work through the entire extensor group. And go ahead and let's load that up again. All the way extend, and now load that up. Good. But very important to get right on the tendon and specifically treat at the epicondylopathy. The patient will let you know that you're on the right spot as well if you can't feel it on your own. And go ahead and let that load down. And let's just do that one more time for the purpose of demonstration. And go ahead. Excellent. Okay. Now, again, we'll do this probably anywhere between 5-10 times, usually equivalent of about 15 to 30 seconds of treatment specifically at the tendon. However, working through the rest of the extensor group, other than treating the extensor group like we've already shown, it's really important to get in between the individual muscles and use the finger to get right between the muscle groups and use your instrument to slide through the deep fascial layers associated with it. And don't forget that associated with the lateral epicondylopathy, the most common involved tendon is the extensor carpi radialis brevis. The second most commonly involved tendon is going to be the extensor carpi radialis longus. So we also want to make sure that we get up onto the supracondylar ridge when treating here. However, there are other important things to make sure that we treat. Other than treating through the extensor group, it's also important that we're going to treat through the flexor group, because remember, if our flexors get tight, if you just lay your hands down, you notice your fingers curl up into a flexed posture, that means that these tendons have gotten tight and they're overpowering our extensor. So every single time we extend our fingers, we have to fight against a much stronger flexor or a much tighter flexor. So that can also play a role associated with our lateral epicondylopathy. We want to make sure that we just treat right through the flexor group. Now, we used concept 3, which was using load associated with the extensors. But let's just say from the orienting of treating the flexors, all we're trying to do is neurologically reset them and help them relax. So we're going to just use simple motion, concept 2 associated with FAKTR. And he's just going to close his hand up and open it up. And remember, when we're doing a neurologic application, this is not supposed to be pro-inflammatory. So it's going to be a lighter treatment stroke. We want to make sure we treat in multiple directions, as opposed to when we did concept 3, the eccentric load on the lateral epicondylopathy tendon. That is a pro-inflammatory treatment stroke or a structural treatment stroke, because we're trying to remodel that tendon, restart the inflammatory process over again, and remodel the tendon from the inside out. And let's just do one more. Good. Now, from there, we're going to go into a couple of nook and cranny areas that I think are really critically important associated with lateral epicondylopathy. One is actually the deep fascial wall that sits between the brachioradialis and the brachialis muscles. Now, I'm going to do this a little bit off angle just because I don't want to get in the way of the video. Normally, I would stand to the front and place my thumb right over here. But for the purpose of the video, I'm just going to come from the opposite side. We're going to start the patient, again, using a motion-oriented. This is going to be concept 2 again. And the patient's just going to slowly drop their arm down into a fully extended position. With lateral epicondylopathy, you're going to know this becomes a very tender area as you're stripping through that deep fascial wall. So once again, we're going to apply that deep pressure through there. And using that motion, we're going to slowly open it all the way up. The last nook and cranny area that I want to show on the outside of the elbow is going to be this small little area between lateral epicondylopathy and the olecranon. Now, it's hard to find. You want to slip your finger right up underneath it. So you can see in the camera right now, I've gone to the lateral epicondyle. I've actually dug my finger right up underneath it. If you have a small finger, you're probably going to be able to accomplish this. However, if you don't, you're going to want to use the edge of one of your instruments to get up and underneath that area. Now, an interesting thing that will happen is on every lateral epicondylopathy, you're going to notice this is almost hot poker pain. This is actually very, very sensitive. As you're treating it, your patient's going to probably wince a little bit. And interestingly enough, what will happen is eventually their pinky and their fourth finger may go numb. Usually my treatment ends as soon as that tingling starts happening in the pinky, so as not to create too much pressure in the area or too much discomfort. The interesting thing, of course, is we're working on the lateral area. The pinky and the fourth finger are supplied by the ulnar nerve, which is on the medial aspect. So again, this is some kind of a fascial pull referral pattern that occurs as we're treating on the lateral elbow that's giving some tug to the ulnar nerve and giving some numbness into that fourth and fifth finger. It's a distribution that happens all the time. It does not give you that radial distribution on the forearm or the dorsum of the hand. The last little area that we may want to look at is, again, going back to the inside of the elbow and checking the radial head and seeing if it's moving properly. So we're just going to pronate and supinate. And what I'll do in that aspect is we can, again, either go to an instrument, use a depth of penetration with my finger, and use an instrument right along the radial head, and now have our patient pronate and supinate back and forth. Go ahead and rotate back and forth, nice and slow. And we can use our instrument, or we can come in with our finger while he's doing that same thing. Again, normally I would come in from this aspect, but because of the way the camera's angled, I'm going to just use my fingers, and I'm going to come across and just slide back and forth in between. Now, if you have somebody who's got a really big forearm, a finger might be a little nicer because it may feel a little cutting using an instrument. But again, remember, FAKTR is not just about using instrument-assisted soft tissue mobilization, it's also about using manual mobilization, or in particular, almost any of our modalities as well. And just let's do one more. Good. So in closing, remember when we're doing our FAKTR treatment associated with lateral epicondylopathy, and again, understanding that this is just for the lateral epicondylopathy, we want to treat pro-inflammatory or a structural application at the tendon. We want to do a neurosensory application through the extensor compartment. So up here is going to be concept 3, using eccentric loading. Through the forearm, on both the extensor or the flexor components, we're going to use our concept 2 motion. We want to get into that deep fascial wall with a motion again, concept 2. And then lastly, we're going into a little bit more of a position-oriented aspect, concept 1, of treating right underneath, posterior and underneath that lateral epicondyle. And again, I treat until I feel that numbness in the pinky, and then I pretty much end my treatment. Also, don't forget that the tricep frequently is involved with the lateral epicondylopathies, so make sure you treat the tricep as well. Don't just focus directly here. I'm Dr. Doerr for Functional Soft Tissue, and this is our second video for Video of the Month for lateral epicondylopathy, and it's FAKTR treatments. Look forward to seeing you at a class soon.